right, we're going to get started with this session, looking at the pediatric innovation from the present innovators' perspective. Hopefully, we're both present and future innovators up here. I'm co-moderating, and we have an amazing panel of present innovators, and we're going to, I think we have about 30 minutes or less, 20, to really quickly get going. So I'm going to just start with a pitch and go around the circle real quick with like maybe a 30-second intro, who you are, and what your favorite current pediatric innovation is that you're working on. Start with Chris Longhurst, my former intern at Stanford.
Thank you, Dr. Kraft, my former fellow at Stanford. I am a practicing pediatrician. I'm the Chief Information Officer now at UC San Diego, recently having left 15 years at Stanford. And my favorite innovation is home monitoring for children with diabetes, which I look forward to sharing.
I'm Andrew Lyon. I'm the Dean of the Schmid College of Science and Technology at Chapman University. Prior to arriving out here, I was at Georgia Tech for 15 and a half years, and in that capacity, we have worked in a very, very diverse team to develop artificial platelets which have potential for pediatric health care in children with cardiopulmonary bypass bleeding issues.
I'm Claudia Hoyen. I'm the Director of Pediatric Innovation at Rainbow Babies and Children's Hospital. My background is in safety, quality, and infection control, so I've been watching people wash their hands in the bathroom. It's just something that I do. My favorite innovation, actually, though, is trying to innovate and making everyone realize at my institution that they are an innovator.
Good morning. I'm Dr. Susan Elliott. I'm a family and women's health nurse practitioner, and I coordinate the nursing research and innovation at Chalk Children's. And our nurses are doing amazing things. You're hearing some of their stories during these days. My personal passion innovation is watching internationally, I've been able to serve on 6 continents, is the mobilization of the clinical church, where you educate the lay people in the care of children and the families, and they're transforming the health care in very remote villages.
Great. My name is James Shuri. I lead commercialization for Texas Children's Hospital and partner with my IS department to lead telemedicine. Very excited about meeting several of the folks in this room over this period of time. The thing that we're struggling with but enjoying is this artificial intelligence discussion where data feeds into a system, algorithms get pro-developed, and then from there applied real-time on a remote patient monitoring kind of basis to decision support. We're interested in seeing how that can play out.
So I'm Charles Palmer. I'm a neonatologist at Penn State Hershey Children's Hospital. I like to develop devices to help newborn infants breathe, and I've done a few different devices, and I'm interested in anyone who wants to talk to me about such a fun field. I'm particularly interested in developing simple devices that could be used in countries that don't have ventilators.
My name is Mustafa Kabir, and I'm a pediatric surgeon at Chalk Children's Hospital here. And I have been working on an approach of taking splenic cells and transplanting them to help with the immune system and in fighting cancer. The talk this morning was very resounding with many of the ideas that we've already been investigating at Chalk.
And I'm Nick Annis. I'm the Chalk pediatrician in chief and the director of pediatric critical care, and co-moderating today with Dr. Kraft. And I'll take the liberty to ask the first question. Anthony said this morning that innovation is not an option in pediatrics, and my question for the panel is, how do we go to the CEOs, the directors of our divisions, or the chairman and say, we need the time and resources to allow our faculty to have an opportunity to be involved in innovation? So Jim, do you want to tackle that one?
I can only speak to our organization, which is we have a wave of physicians that are joining that have an interest in this area, and those physicians are sharing their voices that we need the ability to listen to our own clinicians when they tell us there's a need, and that voice builds when you have a number of folks from different departments all say this is a capability we want, either outsourced through something like iSpy or something that maybe an FTE gets used to or in campus. And the best way to make the overall organization come to one point is to have that voice magnified and expressed across multiple departments.
I think a good place for that voice to start is in all of the safety and quality work that we're doing. People already understand that framework in terms of what it means to be a high reliability organization. First thing, we've all been working on our bundles and we work on our culture. But if you follow the path of a high reliability organization, you end up at human-centered design. And so that's really where, as innovators, we will play a role in continuing to help what's already established in our hospitals just grow to that next phase. So that's really what I've been trying to do at Rainbow for the last 10 years.
Chris?
One of the tools that we can use, and you used helping the faculty, and I'm going to go over to helping all the healthcare providers and come out of that academic realm, and that is to use the certification bodies that you want to have that recognition for your hospitals. And for CHOC, it's Magnet, and Magnet requires nursing research, nursing evidence-based nursing intervention. And so it's one thing to say we want to do that, but it's another for then the front office to step with the funds to give the nursing and the other healthcare providers release time and tools with which to do their innovation.
And I think that is the challenge, is the time and the resources to allow people to do this. And you're absolutely right, it goes well beyond the faculty.
Yeah, Nick, I agree that you need to give people some protected time to be able to innovate. Crushing clinicians with full-time clinical work without the ability to improve that work is a recipe for a lot of dissatisfied clinicians. So I give a lot of credit to our CEO, Christopher Dawes at Packard Children's Hospital, who invested tremendously in quality, safety, and clinical informatics. And those three areas work together very tightly so that, for example, when we had a pediatric endocrinologist who was frustrated at the fact that children with diabetes had to fax or take pictures of their glucometer data, he can come back into the information services department, use tools like Apple Health Kit to get that data into the electronic health record, and then spread it to his colleagues in the division.
I'm just going to mention that venues such as this go a long way. So I grew up in Missouri, sort of the show me state, and I think that part of it is that we have to show them. I don't think it's good enough to just say we want to do this. I think we need to demonstrate that we have a passion for this and that we have an ability for this, because otherwise it's wasted money. So I think as physicians and as nurses and care providers, we need to demonstrate our value and our ability to impact further care.
I was privileged at Stanford to lead a team of 20 physicians with time protected in the information services department. And Dr. Paul Sherrick, our chief quality officer, had another dozen physicians with protected time and quality, which really reflects your point, which is that everybody has a role in innovation. But to your point, it didn't start overnight. Chris didn't say, hey, let's invest in 32 physicians, nurses with protected time. It started by showing small wins and building on those small wins.
And I think the other thing that can come out of it, yesterday we heard a lot from the parents how really just building those relationships, feeling appreciated, knowing that people care. By having a culture of innovation, you're really listening to everybody's ideas. And that, as you said, for the clinician who is being crushed by being 100% clinical FTE, to have them have a little bit of time and to have somebody appreciate what it is they're trying to improve goes a long way for people in terms of the joy that they can experience at work. And so there's, I like to call them, the collateral benefits of innovation are really the engagement and the empowerment and the joy that it can bring to people, both families, nurses, faculty, everyone who works there.
I would say with leadership in the room we have here, a lot of it is setting the incentives, whether it's not necessarily protected time, but how you reward the innovation and how you set the framework. So it all comes down to unmet needs and pain points that cross the spectrum and getting everyone from the patients, the families, the nurses, the engineers, et cetera, to collaborate and converge, as Anthony mentioned, as keywords as we move forward. So another question for anybody here. So, in terms of lessons learned, we even tried to do a trial with Google Glass at Stanford, and the HIPAA folks got in the way. What are some barriers you're seeing and ways you've overcome them that could be examples for others across the pediatric spectrum?
One of the profound barriers is very often just reimbursement. right? I mean, so you have something that you think is a fantastic idea, but then you go out and seek some kind of venture fund support for that, and the immediate question is not how many people this can help, but really what's the reimbursement code associated with that, and does that add to your bottom line in a way that presents a value-added proposition. And that's extraordinarily frustrating. You know, if you're a small company and you think you've got some fantastic space to work in, but that space isn't profitable, it really immediately diminishes your ability to make an impact.
So I'm just going to say, I started this project when I was a medical student, so that's almost 2 decades ago. And quite frankly, I don't think I've become much more jaded in that process. So when I was a med student, I knew exactly why I was doing what I was doing. And quite frankly, as I came up with this, the beneficiaries were really going to be people and places that couldn't pay for this type of technology. And so that wasn't, at least for me personally, wasn't a barrier. It was really, for I think many of us, it's when we have an idea, we want to see it come to fruition. I think for most of us in medicine, it's really to make that idea come to life and see how it impacts people, and then sort of get teamed up with people that can perhaps show you ways to commercialize it, because ultimately that's going to make it last longer. If there is no commercialization benefit, most likely the idea will eventually fade away. So I think there are steps in it, but I think it should start out with what is the benefit and what good will it do for people, and then start working on reimbursement and longevity of that idea or product.
And I'll also agree with the example that you just mentioned. The state of Texas decided HIPAA wasn't strong enough, and then so for us, we have to go further in de-identifying data that we want to hand out to startup companies in our area. So we have to de-identify down to 17 points and scramble data. It makes it very difficult to do kind of metadata discussions with a large suggestion that everything should be IRB based with strong consent. All of those are important things that are put in place for very good reasons, but they also can make it very difficult to work with somebody who's trying to build an algorithm or something that can make something useful clinically.
I just want to make a comment from the perspective of someone who sat on a promotion committee, and many of the folk in the audience, I imagine, do sit on promotion committees. We don't see amongst the missions innovation. We see scholarship is required, and those are publications, but there could be another mission, and that could be innovation, and there could be a number of metrics that relate to patents or prototypes or collaboration or even products or startups that could find their way onto the CV and the dossier for promotion. And that would help in an academic institution to have innovation recognized as a mission and something that is acknowledged.
So Charles, let me ask you a question just related to that. How would you make that distinction between innovation and sort of classic research and using the scientific method? Because that question comes up frequently.
I think one has to look at the different things that are needed for innovation, and one could create a team, the recognition of creating a multidisciplinary team, for instance, engineers and clinicians working together. If that was recognized, if that team was productive in applying for funding, for grants, for involving small businesses to be involved, one would have to create these milestones in the innovation process that everyone here realizes is necessary, and provide some kind of recognition for establishing those milestones in the journey before something is commercialized.
Oh, go ahead. Finish up. Sorry.
I'll stop there.
Okay. So I just wanted to tell you that this is actually something that I've struggled for because I've been doing innovation for 10 years. And so really one of the calls to action that I've had for Anthony is to how do we build this so that not only physicians but nurses and anyone who is following some sort of an academic path have an outlet and we can establish those things. Actually, I just got a call from my chairman last night that I got promoted to associate professor, and the platform that I was promoted on was actually innovation. So, and coming from a place like Case Western Reserve University, where I have spent many years at the bench torturing bacteria and, have done a lot of clinical stuff and have also been in education. I feel like to have them recognize that this is really an area that we need to get into is pretty exciting. So I think that if we all work together, through different collaborations and I Spy, that we can develop those metrics and help people move forward.
Yeah, thank you.
From an academic perspective, I think there are many universities that are learning how to do this, learning how to foster innovation. There's a lot of people in the crowd here from Georgia Tech, and Georgia Tech really does understand at a very deep level how to do this. But then there's the flip side. You mentioned the scientific method, and the initial part of that scientific method is making an observation. And those observational studies, that real basic research, is more than just one small step at the beginning of that scientific method. That's really what launches a lot of these bigger innovations we see today. I'm reminded of the 1940s. One of the great pediatric healthcare innovations was the detection of the oxygen analyzer, so that premature babies wouldn't have excess oxygen in the incubator, and which would cause blindness. And so the development of the oxygen analyzer for pediatric healthcare was based upon an understanding of the fundamental paramagnetism of oxygen, right? People who understood that oxygen was paramagnetic didn't know that that was going to lead to the innovation of an oxygen analyzer that was going to save babies' lives, save babies' blindness, and also enable nuclear submarines to have healthy naval officers and a real robust fleet. So those types of things, that little sliver at the beginning of the scientific method that's just the observational sciences, can't be degraded in terms of this overall innovation pathway.
I just want to play devil's advocate for a minute and point out that I think it's a false dichotomy to suggest that innovation and scholarship are not compatible. So I think it's actually critical that as we do innovation, that we write about it. And all of the peer-reviewed journals now have areas for that type of scholarship, whether it's quality improvement or case reports or perspective and editorial pieces. So the group that I helped to lead at Stanford was recognized and grown in part because of the scholarship that was being generated, and yet none of that was grant funded. So it's a new kind of scholarship that's emerging from a byproduct of innovation. And so it's that alignment of incentives, I think, that's really important for leaping over the barriers that you're talking about, Daniel, such as the reimbursement code issues. The home monitoring for children with diabetes that I'm so proud of helping to lead was helping children that Dr. Rajiv Kumar, a pediatric endocrinologist, was caring for. It was helping the clinicians, but it didn't really take off until we found there was a CPT code for reviewing continuous glucose monitor data. And once that happened, bam, all of a sudden it was no longer a pilot. Now we were doing this for every child with diabetes, right? So the alignment of incentives is critical, and the economists, I think, are much better at figuring this out than the clinicians.
Yeah, I think all of us in this room totally agree with that, your position, Chris, is that, innovation needs to be part of academics and scholarship, and that's what this room is, designed to sort of go out and spread the gospel, if you will.
I think that the scientific method itself, too, is in trying to be so objective. As Patrick shared a few minutes ago, the patient got ignored. Innovation in of itself is extremely dependent on the interaction with the patient and the family. And if we're going to really increase well-being and decrease suffering, there has to be, they can bring in the scholarly methods to support it, to tell the story and share it. But there's got to be, if you will, the qualitative side of what's the impact, what's the story, and making it real to that person. Otherwise, it's just something else that was published. It's just something else. But what's it going to do for my suffering? That's what we need to bring to our patients in innovation.
So we've only got about 2 minutes left. I would just sort of editorialize to say that, healthcare is very siloed, pediatrics, et cetera. We need to cross these disciplines and learn from other fields, whether it's design thinking from folks like IDEO up the street at Stanford who bring new elements or lessons from aviation, et cetera, that have informed checklists in the operating room to be on. So anyone want to jump in with very short examples of of how maybe other fields have informed what they're doing in pediatrics and how that might leap forward and to address other challenges. Doesn't have to be a specific example.
Well, you mentioned checklists, and when I read the checklist manifesto, Atul Gawande's book from a few years ago, I wondered how we had ever run a critical care unit without checklists. I mean, it just is so clear that that kind of approach enhances safety, quality, and outcomes. So, yeah, there's no question about that.
I think in pediatrics, we've been really lucky in terms of our quality and safety work, taking a lot of what we do in children's hospitals now from the group HPI, which was founded by someone in the nuclear power industry. So again, really just looking across disciplines and figuring out what are best practices in other areas and deciding how we can use those to better the care for our patients.
We had a visiting speaker about a month ago. He is the chief of transplant at Boston Children's, and we had the pleasure of spending a couple of days together. And it's very interesting because he actually won the first Innovators Award at the Sheikh Zayed Institute now 3 years ago, I think. And in speaking with him, I asked him about checklists and standardization, and he says he almost never likes to do anything the same way because that's really, so at times we certainly need quality and standardization and everything else because it does impact outcomes. But at times to really innovate or do something different, you can't do everything the same way, otherwise you will never make progress. So it was an interesting dichotomy on sometimes you as a clinician have to know when you need to step outside of those bounds to truly innovate or do something spectacular to help that patient.
Daniel, I think I would say that one of the industries we have the most to learn from is simply consumerism. And recognizing how consumer technology is rapidly evolving our experience every day, we should be doing the same thing with the patient experience. A friend of mine last night showed me that someone rings her doorbell and she immediately has a camera, can answer the doorbell wherever she is from her iPhone. Why can't we do that when a patient comes, when a clinician comes to the bedside at a hospital? Every hospital should be telemedicine enabled in the same way. So I think we have a lot of opportunity to reverse technology transfer consumers back to the patient experience.
Well, I think we're out of time by like 2 minutes. So with that, I'd like to thank the panel. We'll be here all day and keep innovating.
Thank you.